So going through a next set of few Harrison charts. So this is a picture diagrammatic representation of the optic pathway. This is the right and the left eye. Optic nerve, then the nasal fibers. Only the nasal fibers will cross the optic chiasma. Then they'll follow the optic tract, which will relay in the lateral geniculate body. Then optic radiation and primary cortex. So this is the visual pathway. At what lesions will produce what kind of blindness is very important, that needs to be revised. So autoinflammatory disease in which fever is characteristic. There is adult and juvenile still disease. That is cryopyrin associated periodic syndrome, familial Mediterranean fever, hyper IgD syndrome, Behçet syndrome, macrophage activation syndrome, non-complementic urticarial vasculitis, antisynthetase myositis, Papa syndrome. There is polygenic arthritis, polyderma gangrenosum and Ankeny syndrome, Blau syndrome and gouty arthritis. So coming to the evaluation of excessive daytime sleepiness, the primary things you have to importantly know is insufficient sleep, OSA, narcolepsy, restless leg syndrome, and sleepiness due to a drug or a medical condition. So these are 4-5 other differential diagnoses. So how will you evaluate? Now, difficulty in waking up in the morning and rebound sleep on weekends and vacations with improvement in sleepiness. It is known as it is due to insufficient sleep. If it is obesity, snoring, hypertension, polycythemia will be present, then you have to do a polysomnogram or home sleep test. The diagnosis will be OSA. If there is cataplexy, so cataplexy will be present in narcolepsy. Hypnagogic hallucination, sleep paralysis, that is present in narcolepsy. You will do a polysomnogram and multiple sleep latency test. Restless legs and kicking movements during sleep is restless leg syndrome. Assessment for predisposing medical condition very important, that is iron deficiency anemia and renal failure. And the treatment is dopamine agonist like pramipexole and propinerol. This is important. This is many times asked as an MCQ. Gabapentin and opiates. So propinerol is very important. Sedating medications like stimulant withdrawal, head trauma, systemic inflammation, Parkinson's disease and other neurodegenerative disorders, hypothyroidism and encephalopathy. You will get back clinical history and examination. You will have to change the medication, treat underlying condition and consider stimulants. In case of insufficient sleep, sleep education and sleep, you have to give behavioral modification to increase the amount of sleep. In case of OSA, that is a completely different topic. There is continuous CPAP is a treatment. Uvulopalatoplasty is the dental application devices, and weight loss are the therapeutic options. Causes of cyanosis are decreased arterial saturation, decreased atmospheric pressure, that is high altitude, impaired pulmonary function like alveolar hypoventilation, inhomogeneity in pulmonary ventilation and perfusion of hypoventilated alveoli, impaired oxygen diffusion, anatomic shunts like some certain types of congenital heart disease, pulmonary AV fistula, multiple small intrapulmonary shunt, hemoglobin with low affinity for oxygen. Hemoglobin abnormalities like methemoglobinemia, sulfamethemoglobinemia, and carboxyhemoglobinemia. Peripheral cyanosis due to reduced cardiac output, cold exposure, redistribution of blood flow from extremities, arterial obstruction, and venous obstruction. So when a patient comes with low back pain, and what are the important risk factors for underlying any structural cause? So by history, pain which worsens at night, prior history of cancer, history of chronic infection, especially lung or UTI or skin, any history of trauma, any history of bowel or bladder incontinence, usually age more than 70 years, IV drug abuse, any history of taking steroids, history of rapidly progressive neurological deficit. Examination is unexplained fever, unexplained weight loss, palpation, percussion, tenderness over midline spine, abdominal, rectal or pelvic mass, internal external rotation of leg and hip, heel percussion sign, straight leg or reverse straight leg signs, and progressive focal neurological deficit. So this is a chart enumerating the common causes of headache. There is tension type of headache, migraine, idiopathic static, exertional or cluster headache, systemic infection, head injury, vascular disorders, subarachnoid hemorrhage, and brain tumor. The most common out of all this, primary headache is the tension type of headache, and the most common among the secondary type of headache is systemic infections. So considerations in assessment of patient with chest discomfort. So when a patient with chest pain comes to your casualty, could the chest discomfort be due to acute, potentially life-threatening condition that warrants urgent evaluation and management? So it is unstable ischemic heart disease, that is unstable angina or STEMI or NSTEMI. Aortic dissection, right? In aortic dissection, the pain will be usually radiating to the back. Pneumothorax. In pneumothorax, there will be absent breath sounds on that side of the chest with tracheal shift, and accessory muscles of respiration will be working, as well as there will be rise in the JVP. Pulmonary embolism. Pulmonary embolism, usually there will be a history of prolonged immobilization or presence of DVT, deep venous thrombosis, with sudden onset of breathlessness and chest pain. The saturation will be suddenly low. With the most common finding on ECG will be sinus tachy, and the more specific will be S1 QT T3 pattern. If not, could the discomfort will be due to a chronic condition likely leading to a serious complication. Means that the condition is chronic, but it can lead to some serious further deadly complication. One is stable angina, aortic stenosis, and pulmonary hypertension. If not, the discomfort will be due to an acute condition that warrants specific treatment. So it is pericarditis, pneumonia, pleuritis, or herpes zoster. Herpes zoster will be present along the specific dermatome, and after the resolution of herpes zoster vesicles also, the pain will be there along that dermatome. That is known as post-herpetic neuralgia. If not, could the discomfort will be due to another treatable chronic condition, that is esophageal reflux, esophageal spasm, peptic ulcer disease, gallbladder disease, other gastrointestinal conditions, cervical disc disease, arthritis, or shoulder or spine, costochondritis, other neuromuscular disorders, or anxiety state. So this is a picture slide. So this is a visual slide. So this is a Rosenbaum pocket vision screener. So this is the Rosenbaum card, is a miniature scale version of the Snellen's chart. It is used for testing near vision, and it suspends an equal angle at the nodal point of the eye as equivalent to that of the Snellen's chart. So this is very important. So what cases of syncope you should hospitalize the patient? That is high risk features indicating hospitalization or intensive evaluation in case of syncope. That is chest pain suggestive of coronary ischemia, features suggestive of congestive heart failure, moderate or severe valvular heart disease, moderate or severe structural cardiac disease, ECG findings suggestive of ischemia, history of ventricular arrhythmias, prolonged QT interval that is greater than 500 milliseconds, repetitive SA nodal block or sinus pauses, persistent sinus bleeding, bi or trifascicular block or intraventricular conduction delay with QRS duration, that is broad QRS complex, atrial fibrillation, non-sustained VT, family history of sudden cardiac death, pre-excitation syndromes, Brugada pattern of ECG, palpitations at the time of syncope, and syncope at rest or during exercise. So if all these features are present in a patient of syncope, any of these is present, it requires further evaluation and hospitalization. Now coming to a very important chart, this is the difference between cerebellar, sensory ataxia and frontal gait. So it is a wide-based gait in case of frontal gait as well as cerebellar ataxia, while sensory ataxia, which is a narrow-based gait, and the patient looks down. The velocity is variable. The velocity is slow in sensory ataxia and very slow in case of frontal gait. Stride, irregular and lurching, regular with part deviation and short and shuffling gait in case of frontal gait. Bromberg sign may be positive or negative in case of cerebellar and sensory ataxia. Oh, I'm so sorry. Bromberg sign may be positive or negative in case of cerebellar and frontal ataxia, but it is unsteady and false in case of sensory ataxia. Heel to knee test is abnormal in case of cerebral ataxia. Initiation is normal in case of cerebral and sensory, and hesitant in case of frontal ataxia. Turns is unsteady in case of cerebellar ataxia. It is hesitant and multi-step in case of frontal gait, which may normal or abnormal in case of sensory ataxia. Postural instability is one class. So is mild in case of cerebral ataxia. It is profound in case of sensory and frontal gait. Falls are very frequent in case of sensory ataxia and frontal ataxia, and it is a very late event in case of cerebellar ataxia.